All right, so let's get started. Good evening from very cold New York City. It's 34 degrees outside, although it's not raining. We'd like to welcome all of you to our next session of Virtual Tumor Board. Today, we are discussing non-melanoma skin cancer. We have an amazing panel. Our case presenters are Dr. Jason Rich from Washington University at St. Louis and Dr. Ryan Gifford from MD Anderson Cancer Center in Houston. Our discussants are Dr. TJ Ao, Dr. Karen Choi, Dr. Cecilia Shamalbach, and our usual panel, I see Dr. Michael Moore and Dr. Don Veed also here. All right, so since Dr. Rich has a case to do, let's get started. Jason, go ahead.
Sounds good. Let me share my screen. Okay, can everybody see that?
Yeah.
Wonderful. Well, first of all, it's a joy to be with you. So thank you very much for the opportunity. It's great to see some wonderful familiar faces out there, and it's great to be with all the fellows. And I'm sorry, my fellow is in my surgery right now, so he can't be there, but I'll tell him about this case afterwards. So to start off, this is a 70-year-old male who presented with a 5-month history of a progressive, slow, right-sided facial paralysis, as well as pain with mouth opening. He has a past medical history that is significant for a right external auditory canal basal cell carcinoma that was attempted, the resection was attempted by a Mohs surgeon. However, there was positive margins, and this was back in 1995. And so he was referred to an otolaryngologist who performed a subsequent sleeve resection at that time. I don't have all the records of that, but apparently there was considered enough high-risk features that he underwent postoperative radiation therapy that same year. He had done well for quite some time, and then a recurrence was noted almost 20 years later. And so a radical prostatectomy was performed by an otolaryngologist.
And this 2014 was also BCC.
What was that?
The 2014 was also basal cell?
Yes, it was basal cell carcinoma, correct.
If you please mute your microphone if you're not speaking, thank you. Okay, go ahead.
So on physical exam, he had a complete right facial paralysis. All the other cranial nerves were intact. And you can see here, he had a collapsed right pinna into his large radical mastoidectomy cavity. And within the ear canal, there was quite a bit of granulation tissue and drainage.
Okay.
Oh, you mean salad?
Let's stop here. Let me ask Ryan. Ryan, what's your routine for approaching these cases at MD Anderson? When the patient comes in, what do you get for imaging?
We'd probably get both a CT scan and an MRI for local regional imaging here.
Okay. Do you guys do routinely PET CT or just a CT?
Probably not for this case, and it's a little bit provider dependent. For a basal cell, assuming that we agree with that pathology, I probably would not get a PET CT.
Mm-hmm. What about you, Cecilia? What do you guys do in Temple?
Yeah, so definitely a CT scan. It's basal cell, so unlikely PET. Depending on what I saw on the CT scan, may want to dedicate a temple bone CT. And then certainly with the nerve being out, oftentimes MRI just to better delineate back to the skull base. The only other thing I would do is part of the workup if possible, but I know it's been 9 years, trying to get the original path slides to get re-reviewed.
All great points. I think most of us will agree that, as Ryan and Cecilia said, especially for basal, so especially when you're dealing with this area, really both MRI and CT are complementary, and most of us would do both. Okay. Jason, what did you do?
Can we have everybody mute their microphones, please?
JJ, can you?
I like your hair, beautiful. Can I see your hair?
JJ?
So I'll just move forward. So,
Yeah, go ahead.
so a biopsy was performed of the right mastoid cavity granulation tissue that showed basal cell carcinoma. Let's see here. And so for imaging, we did get an MRI for the same reasons that were mentioned. And we, as well, we did get a PET CT. And so what you could see here on the MRI is an enhancing lesion extending from the mastoid cavity along the skull base, along the styloid apparatus into the parapharyngeal space. And this was also FDG avid on PET CT. And you can see here, this is the carotid artery here, the flow void. So you can see that this lesion was coming right up and around the carotid artery.
Oh boy, easy case. All right. So let's ask TJ, what would you do?
Well, I also, with the MRI, especially like to see what's going on, really get a sense of what's going on at the skull base. What was the tegmen like? What was the dura like? What was the stylomastoid foramen enlarged? Really, your main question here is, are you dealing with something that's resectable or unresectable? And the carotid, looks involved, which makes this, potentially unresectable. But to me, I really want to know what the extent of the carotid involvement is, and really getting a really good sense of what's going on at the skull base is critical. So that's my question for Jason. This is a great cut, but what did the rest of the image tell you?
That's a great question,
point.
TJ. So the skull base, the tegmen was clear. The carotid artery was more or less encased, or that lesion came up to about 180 degrees of the carotid, maybe a little bit more on the different cuts.
Yeah.
So 180 degree, but not complete encasement.
Not completely, 180 to 270.
And I assume no intracranial, no dural enhancement, or so extracranial, as the neurosurgeon says, extraaxial disease still. Okay.
Infratentorial.
Infratentorial. Okay, sounds good. Let's see, Ryan, what would you do?
Well, I guess on the basis of these images, I'm still concerned that it's not resectable with relation to the carotid artery. So if I'm considering doing surgery, I'm going to want some dedicated vascular imaging in this, and be prepared to remove that if that's the consideration. Those are my thoughts. The rest of it, this is a very complex location, but the rest of it technically can be removed.
Yeah. Very, very well. Cecilia?
I agree. Certainly, this is where, I just find the multidisciplinary tumor board to be so helpful in presenting. And likely this is a case where you're not going to know until you get in there, especially if it's just 180. But it's obviously challenging and concerning.
Yeah, I agree. I think that, we'll let's see what Jason tells us, but this is one of those cases that my first inclination is like, what is that thing called vismodegit? Just thinking more that way. But anyway, all right, Jason, let us know what you decide.
Sure. So all those points were spot on. We did discuss them at our multidisciplinary tumor board, and I think a point that's very important is to get the prior radiation fields to our fellows. And so we did dig back in and get the radiation fields, because there was a question: is the MRI findings radiation effects? Is it actual tumor? And oftentimes, for basal cells or skin cancers, radiation oncologists will give electron beam radiation, which is more superficial to the fellows listening. And so you have to really pull the records, though, to know if it was superficial radiation or if it was actual IMRT or opposing fields back in the day. Unfortunately, the fields did extend to the skull base. And so he did get a full dose of radiation and deep into the skull base and the parapharyngeal space. And as mentioned, there was concern about carotid artery involvement. And so these were the treatment options that we discussed. First of all, reirradiation. We were not too keen about that. The efficacy of reirradiation is not as high.
Jason, before you say, can you bring up your treatment options and then we discuss and then you tell us what you
sure.
What are the others? Okay, so this is
So we also
go ahead.
Is it?
No, go ahead.
Okay.
All right.
The so the other thought, the other option is he was otherwise healthy, 70-year-old, surgical resection, reconstruction with fresh tissue, and then reirradiation. And the feeling was, like was mentioned, we don't know how involved that carotid artery is until we get in there. And so we did not do vascular imaging like Ryan had mentioned. We did think about that, and I think that's an excellent point. Our feeling was that if we got in there and it was scarred in, the tumor was involved, we would abort and we would not. The decision was made not to take the carotid artery if that were the case.
Right,
but the other.
Let's discuss, what about using vismodegib as a neoadjuvant and see what the response is and then attempt for surgery?
We definitely discussed palliative vismodegib. And, that's just so poorly tolerated, it's so expensive. And then as soon as they go off, it flares back up. We have toyed around a lot with, can you give neoadjuvant vismodegib? And then would that impact your final treatment? There's a few case studies that I'm aware of reducing your surgical or radiation fields, but there's not much data to support that. It's safe, in my opinion, to really modify your surgical plan after giving neoadjuvant. You don't know if it's a concentric shrinkage or if you're going to be having little deposits of tumor. So we're a little bit less inclined to do that.
Okay, so these are fantastic options. Let's ask Karen. Sorry, Karen, I haven't picked up on you yet. How would you approach this case? And I think, what's the deal breaker for you? Let's put it that way.
Yeah, that's a good question. It's funny because it wasn't a basal cell, it was a squame, but I had a patient that I operated on the other day that looked almost exactly like that. And so we ended up actually taking him to the OR. But I guess my question really, the concern I have is the imaging. I'm hesitant in a 70-year-old that's already had multiply recurrent basal cell, although it was 20 years ago, the recurrence now is pretty aggressive appearing. And so I'm concerned at the thought of bringing him to surgery with the potential of not being able to get negative margins. But I guess the question I would ask is even if I can't get gross total resection, if I can get kind of either remove the gross tumor, but maybe leave behind like microscopic or something like that, would that help as far as the adjuvant treatment? And if it was felt that would be helpful, then that could be a possibility as well. But
okay, so let me ask you this. I'm just going to ask everybody: knife, no knife?
I have a couple more considerations, and then I'll give you my answer.
Yeah, there's one more.
Sure.
Well, for the reirradiation, just one thing that, of course, I think nowadays everyone would throw in protons as a consideration. It might, it might change your decision making because it might decrease the comorbidity somewhat. They might be able to deliver a little bit higher dose in that at the skull base than they had previously. So as far as the other question I had, Jason, do you guys ever do balloon occlusion tests for this type of cases? Even I know you said you weren't going to take the carotid, but even in case something happened, you had
Injured.
just knowing.
We do. We definitely do the carotid balloon occlusion.
Did you do it for this case?
I don't believe that we did.
Okay.
No.
So
So,
basically
I mean,
the question, you go ahead.
I might consider that because, obviously if there's a really high risk, that might change my decision for surgery, no surgery, if they're at a high risk of a stroke, surgery.
Okay.
So you're
Um,
asking knife, no knife. I actually have a heart to heart with the patient, engage their risk, their level of risk aversion,
mhm.
So I think that for me, that plays a really heavy, when there's not really a clear answer, I usually use the patient to help guide me to their right answer,
Yeah.
not my
But
right answer.
imagine classic New York patient. What do you want to do, doctor?
My New York patients are a lot different than your New York patient. But in most cases, if the patient really wants to, their best chance at cure, I'll offer them surgery.
You do offer surgery.
But if
Okay.
they're, very averse to, it really is kind of 50-50 and it depends on the patient.
Sure.
You have to
No,
have
I hear, and that's the whole point of having this discussion, because of, this is a prime example of a case that's really, really complex, and there's not a right or wrong answer here. Let me just ask, and I just want to hear your philosophy and how you approach it, as you said. Ryan, what would you do at MD Anderson?
I think that there's one more option, and maybe there's some preliminary data that was presented at ASCO on use of cemiplimab for advanced basal cell carcinomas. I don't know that there's much data. Certainly, it's not FDA approved for that. But we have treated some patients. I don't know if there's enough to provide any recommendation, but that could be a consideration that we've discussed.
They would have to fail vismodegib at first, though, in the most without a trial, right?
I believe that that's the case. Yes.
Would you operate?
I would not operate on this patient.
Okay.
I think that there's a high chance of numerous lower cranial neuropathies aside of the carotid. That doesn't mean that it can't be done. I think that there's a very high possibility for causing a major problem.
Okay, Cecilia?
Can I ask a couple of quick questions? Is this a very high functioning 70-year-old, or like came from a nursing home in a stretcher 70-year-old? And then
no, he's high functioning.
And was there did this bother him a lot, like very painful, weeping, impacting his quality of life?
Yeah, he was having quite a bit of pain, difficulty opening his mouth.
So for me, that winds up playing a huge part. So I've had great success with vismodegib in the palliative setting. I think, Jason, I appreciate your point, and I've experienced this. I've been on the receiving end where a patient was treated with neoadjuvant vismodegib, grew through it, then gets referred to me, and I went really wide, free flap. Patient was set up for radiation, and right after radiation started popping just outside of the field. So I think there is truly these nests or fronds, and then it shrinks down and they leave these deposits. I can tell you, for me, if he was debilitated, I would go with palliative vismodegib. If he was high functioning and this was impacting his quality of life, I would be willing to offer surgery with the understanding that there's a very good chance there could be residual deep disease left. And then maybe that's when palliative vismodegib could come into play. Okay. But it goes back to the candid conversation.
Sure. In the interest of time, I'm just going to do a quick poll of the rest of it. This is a great case, by the way. Mike Moore, what would you do? What would you recommend?
Yeah, probably would err on the side of not surgery, but depending on the patient's discussion. I think not just the carotid, but it seems so ill-defined along the paraspinous muscle and the skull base. I don't think you would almost certainly have, residual disease, not just microscopic, even with an aggressive approach.
All right, Jeff?
You're only as good as your closest margin. I would say no surgery.
Okay, Don, Dr. Weed?
We would probably operate on that patient. I think there's my experience with neoadjuvant vismodegib is exactly as discussed. I see my patients like this after they've been treated that way and have this, and it's a very frustrating thing. If you're going to reirradiate free tissue up there after temporal bone resection and resection of this, and all the considerations about the carotid are what they are. is going to allow you to do that more safely.
Okay, great. So thank you. This was excellent. That's exactly the point of this tumor. So for the audience, just I want to say, we have to be honest with ourselves. We all know vismodegib, as non-invasive as it might occur, it's palliative. And the best chance, and I agree with everybody feels that the chances of cure for this patient is not really high. Now, the next thing better than cure is having long-term control of the disease with reduction of the symptoms. And if we are honest with ourselves, in good hands, that's the best chance again with radiation, with surgery again. So, but there is no right or wrong answer. There is no good answer. This is a bad disease, and it's really the clinical judgment that determines what to go. So, Jason, tell us what you decide and how you proceed.
Well, I can tell everybody honestly that I was as eager to operate as all of you have mentioned. And we discussed all the different options with the patient. And as TJ had said, I also use what the patient is feeling, their interests to help guide the treatment plan. It's kind of a partnership. The patient was very eager to move forward with surgery to try and cure. And we had a very open discussion about the risks of surgery, as well as the fact that we very well may abort if based on what we find. And so we did move ahead with surgery. We did a total auriculectomy, and I think this was important to mention just because it had been previously irradiated. So if we were to leave it, it would have fallen off and caused problems down the road. So we removed that. A radical podectomy was done. A selective neck dissection was done mostly for exposure, control of vessels and nerves. And then our otologist performed a subtotal temporal bone resection, probably the most thorough subtotal I've ever seen, where the carotid artery was skeletonized, the cochlea was removed, and then a free flap reconstruction. And so we definitely approached this in a very methodical way. The lateral temporal bone was removed up to the cochlea. We approached from the neck. We encountered some scar tissue. We were able to work past that when we got to a certain point that we couldn't safely work along the carotid artery. Then our otologist continued working on the subtotal temporal bone, and we were able to meet within the temporal bone. And so it actually, not every case works out great. This actually worked out better than we had hoped for. And facial nerve reconstruction. So this is the defect here, the middle fossa dura, posterior fossa dura, and then you can actually see, you don't get to see this very often, the internal carotid artery coursing from the neck through the temporal bone. We did have to leave some microscopic disease. I don't know if you see my pointer, just right here along the carotid artery, but for the most part, the gross disease was removed. And again, to the point that Minnie made, you don't really know what you've got until you're in there many times. And so patient got reirradiation. I don't have long-term follow-up. All I have is 7 months. No evidence of disease recurrence. That doesn't mean that, of course, he's disease-free in the long term. Time will tell. But, you know, I think just a few points I would like to make is basal cells are very challenging because there's such a slow growth. I would imagine this has been growing since 1995 and has never stopped. And that's the reason it was so infiltrative. So, you know, I think maybe I'll stop there for the interest of time. I don't want to take up more time.
That's a great case. And I would tell to the audience that you will see these cases in your practice, regardless of where you are. These, as the population ages, you're going to see more and more complex skin cancer, especially with the head and neck surgeon. You're only going to see the worst one. And this case is a prime example of how much you can do with good planning and having a multidisciplinary team. And same as you guys, we have a very active otology department here at NYU, and they are more than happy to do the total temporal bone resection or whatever we ask them. These guys do this routinely with neurosurgery, and sometimes you even involve neurosurgery as well. I don't think you needed to do neurosurgery to do a dura repair, but even when you get to that, they do it. And it's all depending on your judgment and the biology of the disease, as Jason said. You know, This patient had a few things in his favor, and even when you're leaving microscopic disease behind. But it's a very challenging, and you have to pick your fights carefully. Let's just have a couple of last comments before we Ryan starts. Oh, any further comments? Jeff, Mike, or Karen, or Cecilia? All right, let me ask you this. How do you guys follow this patient? Would you do an MRI every 6 months, or do you even consider putting him on vismodegib afterwards?
I think if you re-irradiated him, I would do a 3-month MRI and then every 6 months for a while. I would not start vismodegib unless you saw progression.
Okay, fair enough.
I agree with Mike.
Yeah.
I agree. I mean, there have been some studies that have showed preliminary good results using long-term low-dose vismodegib as maintenance, but it's usually in the setting of patients that have diffuse disease. Obviously, it's pretty demanding. Those patients still have drug holidays, and it just decreased recurrence by 25%. I think if they had residual disease, I wouldn't start the vismodegib until they became symptomatic, and I would favor re-irradiation. And I just, love the point of vascularized tissue there so that you have that option, which is another reason to irradiate, or is another reason to operate, rather.
Great. Yeah, and I think Jason proved the point here that go big or go home. This is not a surgery.
Well, not everybody should receive a surgery. I will definitely admit that. But
Bobby, can I make one point for the fellows that are on the call, just so they know? Right now, there are 2 phase 2 clinical trials for neoadjuvant use of vismodegib. So I think it's just important to know that if you are going to suggest it, that it really should be in the context of clinical trials and certainly discussed via tumor board. And in both of those trials, I think one is vismodegib and the other one is this sonegib. But in those trials, it's just 12 weeks, and then they go on to surgery. So it's a moving target right now, which is good for our advanced basal cell patients.
Yes, I completely agree with that sentiment. That whatever we do, we really should promote clinical trial as a surgeon. Okay, well, Jason, thank you so much. I know you have a patient in the OR, so if you can stay, we would love to have you. But if you need to go, by all means. Ryan, would you please bring up your presentation?
Thank you.
Can you see that?
Yes.
Okay. So this is going to highlight some some points that were made, and I think it'll be good discussion. Interestingly, I saw this patient in follow-up today. Didn't know that. This is a guy who presented to me with a right neck wound, and this was what it looked like the day that I saw him. Here's some brief surgery that led up to when I saw him, and I can read through this, and then we can talk about some different points. Again, no knock on the Mohs surgeons here. Just so happens that we don't see all the patients that they treat well. But this gentleman had a Mohs surgery for a cutaneous squamous cell carcinoma on his lower lip. It had some perineural invasion, but negative margins, at least by report. It's hard to review those on the outside. And shortly thereafter developed a level 1B nodal metastasis. It's possible that was present at the time of the Mohs surgery. In any case, had a nodal excision, which demonstrated a fairly large node with extranodal extension, and he received adjuvant radiation for that. Unfortunately, had basically progressive disease at the end of radiation that was in the soft tissue, had some resection of skin and a level 1 dissection, and presented to us with the picture that I just showed. With basically draining purulent sinus cavity, likely with persistent disease. And this was his scan when I saw him.
Okay. So looks like this is actually in the skin, in the soft tissue, and goes deep to the mandible.
Yes, that's correct.
Okay.
And I should say he had no evidence of any persistent disease at the primary site on his lower lip.
Okay, so that actually brings a good question. Now you have a compromised mandible. What's your routine for mandible assessment? Let's see. What do you guys do for, bone involvement? Do you do MRI? Do you do cone beam CT? Do you go old fashioned like Memorial way, just feel it, if it's moving, it's okay?
At MD Anderson, we usually use both CT and MR. This patient had no cortical involvement of his mandible, and I do not believe that he had an MRI prior to me taking him to the operating room.
What about, let's see, Mike, what would you do? What's your routine here for these kind of soft tissue tumors? Possible
Yeah,
involvement?
probably a physical exam and most likely CT. I don't know if I would add MRI unless there was some kind of ambiguous finding on the
Karen,
CT.
what about you?
Yeah, I think I would just start with the CT.
Okay. Well, I have to say, I guess I'm in the minority here, because the more and more I see soft tissue, especially post radiation, and especially when I want to look at the bone marrow, I'm becoming more and more convinced that the MRI is actually helpful, because this is very close to your mental foramen. And although your cortical bone might not be involved, is the question of, is there any bone disease in the bone marrow? But I can understand that. Probably not going to change your management too much, but I guess we are in the minority here in NYU. We do a lot of MRIs now. Okay.
That question will become germane later.
Oh yeah, I'm sure.
So he's got
biopsy at CC. And,
yeah, we don't have any biopsied evidence of recurrence, and we have this image which gives us suspicion, but it's draining purulence. So what we did for this was managed his infection, and basically got the skin to heal. I guess I shouldn't show that picture yet, but got it to heal for the most part, but still had some draining sinus cavity there without clear evidence of persistent infection.
Okay. Did you biopsy anything?
There wasn't really any focal mass to biopsy, either by FNA or by externally.
So what was the diagnosis then?
Well, we presume that he might have persistent disease, but he still had a draining sinus in his neck. And the decision was made basically to take him to the OR and resect this non-healing radiated tissue. He had recently gotten 66 gray of IMRT. It was not electrons, and we weren't sure exactly what was going on.
I see.
So we took him back to the operating room and found some infiltrative squamous cell that was really just in the soft tissue near the bottom of the mandible, not adherent to it, but near. We resected this, but did not feel good about it. Clearly, we stuck some fresh tissue up there, and then I guess the discussion is for the team. You have this wound that you've now fixed, but some infiltrative squamous cell, and what to do afterwards.
So let me ask you this, and this is the point that I usually grill my pathologists. First of all, I have to say, kudos to you to kind of make your decision saying, I'm going to take this out, because I'm very reluctant to operate without a biopsy, but I can understand exactly the logic here, and I think you did the right thing. Was there invasive island? Was it just infiltrative? Was it one tumor? Was it all over the place?
It was an infiltrative area that looked just like fibrotic scar tissue and almost like a rind of an abscess along, just inferior in level 1B and under the mandible. I want to say that we had tried to do FNA and couldn't determine that there was any cancer here, but
got it.
We had a high suspicion for it.
Yeah, no, I understand that. Okay. So there are these squamous, are they deep in the tissue or they were not part of
Yeah,
the
they're in
skin,
the soft tissue, not under the skin.
Got it. Karen, you're up. What do you do?
So, so at this point, it's completely excised. Margins are negative, and you're happy with how it's the resection, or
It healed. It healed. I was worried that it was going to come back. I didn't know the first surgeon, but for all I knew, he or she could have done an excellent job resecting that cancer, and it just didn't respect the surgeon, came right back. So I was worried it was going to come back.
But and you are also worried about your mandibular margin?
No, I wasn't worried about the mandible.
Okay.
I wasn't worried about the bone, but the soft tissue nature of it made me concerned. And actually, my question for the rest of the team is, would you re-irradiate? And the radiation oncologist said, hey, he just finished, not even 3 months ago. We don't think that's a good idea. And adjuvant chemotherapy or immunotherapy was not approved and or not possible.
Yeah,
at that time. This was in 2018.
Yeah, no, I that's very, even nowadays, if you don't have any evidence of disease, it's hard to
justify
prove anything. Yeah. So there's a question from the fellows for you, Ryan, that says, when you are in the OR, do you send the frozen section?
It's exactly what I did.
Okay.
So I made that. You can see I was feeling this, and that's my skin marking, and I made one skin marking, and I thought, I should probably go higher than that. And actually, I made that superior incision first, and this tissue right inferior to the mandible, I sampled and sent for frozen, and that was positive.
That was positive. Okay. All right.
Correct.
So for the fellows, you see, as you can see, although Ryan is being very humble here, but he is going through every single step that, all we should do, that just to making sure that as Dr. Spiro used to say here, the punishment fit the crime. And, it's very important to have a kind of a systematic approach. Okay, so question, would you re-radiate or not? Mike, more?
I think it's a gut call. I do what you were mentioning. I carry it over to the pathologist on the spot and like to have him do kind of an en face cut, see kind of what you're seeing under the microscope, how it respects the margin. Ones like this where you're near a lot of valuable real estate, I would kind of try on the up front end, assess what you feel like you legitimately can save functionally and what you can't. You go find, if you can save it, the hypoglossal, and take everything kind of superficial to it out. It may be that you assess going in and that's all involved. But I agree with what's been said. You never leave there feeling great about it just because it's scar tissue versus cancer.
Yeah.
I think we've all had ones like these where that wide margin ends up being way too much and times where it's way too little. Just because it's really hard to delineate what's.
So would you twist the patient's arm to have re-radiation?
I wouldn't if we're within 3 months of it. I don't think. Yeah.
Okay. TJ?
Well, I had a quick question. I might have missed this. It sounds like outside they reported a 1B dissection, but no, they didn't do the rest of the neck.
Correct. I did the rest of the neck in this surgery, though.
You did.
Okay. I did not mention that.
Okay.
There were no other foci, no other nodes, just soft tissue.
Yeah. And you said this was one isolated mass, even though it was kind of desmoplastic.
It wasn't a big
fibrotic
mass, but it was not well defined.
It's basically an ill-defined soft tissue focus.
So, and I didn't hear if you got the radiation records from outside. Did you get what they?
Yes, we did. They irradiated, the lower lip, the jaw down to the mid neck.
Yeah.
Yeah, I think for the lip, this is close.
Yeah,
I mean, I know it's a ticking time bomb, but that's short after radiation. If it's an isolated, it seems like there was just tissue left that grew back. I think if I was confident I got that focus out with surgery, all the other nodes are negative, I probably wouldn't re-irradiate, even though it's kind of a ticking time bomb.
Sure.
I mean,
Okay.
you reported extensive perineural in the original Mohs. I mean, I think this is probably what you're seeing is, perineural, and radiation is really the only thing, and I think I would assume the rest of the field got radiated and have to sit and watch and see what happens.
Yeah.
Okay.
Well, that's
Cecilia,
exactly what we did.
RT, no RT. 1 second. RT, no RT.
Did you call me?
Yes.
Oh, I was thinking you asked if we'd have to twist the patient's arm to re-irradiate. I think I'd have to twist my radiation oncologist arm if they've already been radiated and the margins are negative, but this is someone I'd follow really closely afterwards with MRI.
Okay. So I guess the point is, for all of us, although we take Ryan's word that although he had negative margin, he did good surgery, everything was good, he doesn't feel very good. He's worried. We are all worried. But at the same time, we cannot really, in a clear conscience, recommend re-RT. And for the fellows who haven't seen re-RT, you re-RT this patient, say goodbye to that mandible, just sign him up for your fibula right away, because that mandible is not going to survive. But anyway, that's another day. Okay, Ryan, tell us what happened.
So, he came back at about 8 weeks and had a soft tissue recurrence, right?
Oh my God.
Above the area of the flap, as you can see. And this is what I was worried about. The radiation oncologist refused to give additional radiation. The medical oncologist didn't have another treatment that they could offer him. But, they always say the number one reason to give adjuvant radiation is if the surgeon says they're worried about it. So
I just
here
want
we
to
are
make
with,
a point. Yeah, that's for all of the audience. This will happen. This is exactly what we are all worried. Unfortunately, there's no rhyme or reason to it. Sometimes you do these and nothing happens, and sometimes you do this exact same scenario and this will happen. You will never forget those cases that you do this beautiful job, negative margin, everything great, and like freaking 8 weeks later, here it is. Hello, cancer.
Yep.
Okay.
That looks to me like it's either a perifacial node or the marge, for where your recurrence is. So I don't know if there's a lot you could do about that. Probably the sentinel node at the original procedure would have maybe picked that up.
Well, the original procedure, unfortunately, is long gone now. I think this is just, yeah. Okay, so what to do now? Let's see, Dr. Weed, let's ask the senior member.
Well, if you're 8 weeks out from surgery, you've proven two things. Radiation didn't work and surgery didn't work. To defend the radiation oncologist, you cannot re-irradiate 3 months out from finishing radiation. I mean, you can, but it's just not the right thing to do. So on the other hand, if this presentation were a year out from radiation, then I would absolutely re-irradiate him. And, I don't think you'd have to push the radiation oncologist to do it either. I think they'd be able to do so. And you're right about the mandible. It's going to be an issue. But now, goodness, I just don't think you're far enough out from radiation, even now, to re-irradiate after you try and do another salvage surgery. You can do it, but as I said, you've proven surgery doesn't work. So this might be a scenario for immunotherapy and follow him and not rule out the possibility of a salvage surgery if they have a good response and you get yourself farther out from radiation such that you could then consider re-irradiation post-op. But if you're just even 4 months out from radiation, hands are pretty well tied.
Yeah, I agree with that. I think we are moving toward non-surgical, non-radiotherapy. And, those of you who have read that the randomized clinical trial out of Australia about adding chemotherapy to radiation for skin primaries, that was a negative trial. So platinum-based at least doesn't do much. So now we are entering the dark hours. So Ryan, what did you decide? Time to leave Texas?
Sorry, was there a question there?
I just had a
So what did you
I
decide
had a
to
quick
do?
question just for the experts on the group here about a similar but different scenario that I've run into, and I'm just curious to see what other people do because I've not been able to find a literature-based answer for it. But why don't we finish the case first?
So this gentleman, this was a time when cemiplimab was not approved yet. We were running a trial on that. He was enrolled on that trial, received actually one dose on the trial, and then the FDA approved it for an unresectable metastatic disease, and then continued on it. He basically had rapid involution of this tumor, and to this day remains without evidence of recurrence. Unfortunately, he had some moral pain and some dental extractions right after that, which led to this.
Yep.
Gift that keeps on giving.
Classic.
And, despite an aggressive first surgery where we preserved his hypoglossal nerve and some other things, that was not the case after this. So then this is a little bit of a different scenario, but it was the full case. Just to tell you that then he required mandibulectomy and a secondary flap. And thankfully, he did not have any evidence of cancer in his mandible or any of the resection specimen.
Now, let me ask you this. So, I mean, this is amazing, and that's what we are really seeing nowadays. Is he still on cemiplimab, or is he off?
Yes, he is. It's the same question that's asked in melanoma about adjuvant immunotherapy, or he really didn't receive it in an adjuvant setting, but what's the long-term thing? Most of the trials just arbitrarily selected 12 or 24 months. I believe he's still on it more than 12 months later.
Yeah. We also have a series of patients that we actually offer them cemiplimab or pembrolizumab, those who are advanced age with primary nodal disease, without radiation, without surgery, anything up front. And a lot of them have excellent response, just amazing. On the other hand, I just have a patient right now that I'm going to operate, and we tried to do that and didn't respond at all, and the tumor is progressing. Okay, so
can I ask a question to Bhavik and Ryan? So when you do have them on cemiplimab, how often are you or your medical oncologist doing imaging?
Well, is it on? You mean in the neoadjuvant or the adjuvant setting?
No, the adjuvant setting there.
We've still been doing it about every 3 months, so they're getting. Usually, they get that every month or so, 4 to 6 weeks.
Yeah. I agree. I think majority of our patients, if they're going to respond, they respond after about 2 or 3 doses. You will see the response, and it's not a minor response. It's very, very dramatic. Like the nodes will completely go away, and those are the ones that I think we do still every 3 months. Most, and I've been surprised how well they tolerate it. We have a 97-year-old who had a prior stroke and everything, and he was on it for 1.5 years, and he basically just had 1 episode of pneumonia, which wasn't bad.
Yeah, we are Neil Gross in my department is leading a trial looking at that in the locally advanced, not unresectable setting. So basically, like you're saying, even T1, T2 with nodal disease. And it's you see some remarkable responses. I almost presented a case here of a patient that did not respond, but I thought that was less helpful since we don't really know how to predict who will respond and who doesn't.
And so for all of us, I think cemiplimab or PD-L1 for cutaneous response seems to become a game changer at some point. I don't know when and how and which patient, but I would urge all of you to keep yourself up to date and think about these different options for these patients. I think the more important point was, Ryan, that your determination of just, you had a suspicion about this is bad disease, and you had good surgery, although it didn't work, but we didn't give up on the patient. All right, so let's finish. Mike, you had a question for the panel?
Yeah, well, maybe the answer is cemiplimab. I don't know, but I've run into this for adenoid cystics too. So little lip cancer with PNI, and it goes into mental foramen, just on the nerve. But so do you take the mandible? Do you drill the nerve out? Does it matter if they have teeth or not? What you do, because there are little nerves going into the teeth. I've not, and maybe it's small volume disease, but it's a big deal, obviously, depending on what you do. So, we can talk about it in the context of cemiplimab, but I mean, I've certainly seen it with minor salivary gland adenoid cystics. I'm just curious what the group does.
Oh, in terms of chasing perineural
Yeah, like
invasion?
say you have a lip adenoid cystic and you see it going in the inferior alveolar nerve. Do you drill the nerve back, or do you resect half the mandible, or how do you do that? And I don't have the right answer. I'm curious.
I don't think anybody has the right answer, but Spiro again used to say adenoid cystic is a disease. If the patient or the physician lives long enough, it always comes back. And it's really the biology of the disease. We can see that perineural invasion because the nerve is big, we can find it, but that's not the only focus of perineural invasion. So I'm not sure if there is a nerve grossly involved and your foramen is bigger, you're taking gross disease out. That's different. But chasing microscopic disease in one spot that you can see versus all the others, not sure it's going to make any difference. And really, that patient's going to do what they're going to do. If they're not going to come back from the mental nerve, it's going to come back from another nerve. So personally, I do not chase normal-looking diseases, normal-looking nerves up to, because there's no point in it. But I'm very interested to hear others. TJ, you've been quiet. What would you do?
I don't chase.
Oh, is that Jeff?
I don't chase microscopic disease either for adenoid cystic. You have skip lesions, you can take it all the way up to the foraminal valley. You're not going to clear it or cure the patient forever. So I just go to gross disease.
Sure.
I'll take the nerve at the foramen.
Well, even in the context of a cutaneous squame, I didn't mean to jump off subject here. I apologize. I just
even in the context of a cutaneous squame, just gross disease.
Yeah, for a squame, I don't know. Let me ask TJ, what would you do if squame? Do you chase perineural invasion?
Not microscope. Grossly I would, but if I think it's more important to talk to your radiation oncologist in those situations and make sure that their fields include any perineural invasion where you suspect it could go up to the skull base. They usually, ours are aware of that, for adenoid cystic or whatever, and they make sure that those fields are covered. Squame is generally, more radiosensitive. So I think that conversation, I wouldn't take out a mandible for that unless I knew there was gross disease in the mandible.
Okay. Ryan, what's the philosophy at MD Anderson? What do you guys do for perineural invasion?
I have a couple of patients. One is a squame and one is a desmoplastic melanoma who had exactly that. So on the lower lip, tracked through the middle foramen. The squame went all the way through foramen ovale, the enlargement of the ovale. Patient was put on cemiplimab, had a radiologic complete response and refused further treatment. No radiation or anything. And I think it's been a couple of years since that patient was treated. I had a desmoplastic melanoma patient, similar thing, except that patient was not a surgical candidate. He was elderly. He was placed on ipi-nivo, or actually I think just nivolumab, also had a radiologic complete response. Whether, classically we still do the same surgery we would plan otherwise, but I got to tell you that I'm modifying surgeries based upon some of the responses in a case where the surgery would have been extensive. Yeah. So I don't know what the right answer is. There's not a lot of good data to support our modification or doing less surgery. But that's kind of where I've seen myself and my other colleagues doing that with when you see a dramatic response such as described.
I agree with you. I think that's very thoughtful. And you're absolutely right. We do see these amazing responses, especially now with cemiplimab. As I said, it might be a game changer. Cecilia, what would you do? Do you chase perineural invasion?
So a little depends on the location. I'll just speak to squame. So if it's infraorbital nerve, I'll trace it as far back as I can and then clip it. And as TJ said, talk to my radiation oncologist. The mandible is different. I'm not going to take the mandible just for small nerve invasion there. And I do think that cemiplimab, to your point, gives us a new option that's very promising. Unfortunately, in my patient practice, what I've experienced, it's that transplant patient. It's the challenging patient who, again, for the fellows, there right now, it's not approved for our transplant patients. At least the original trials did not include immunosuppressed patients. So that's the group that I don't know what, Michael, if that's been your experience, but that's the group that I really, you just kind of throw up your arms and do your best, and you may need to be more aggressive surgically there.
Absolutely. I see Jason is back. Jason, do you chase perineural invasion?
No, I would agree with everybody. I've been modifying my surgery to just gross disease, and especially weighing out what the morbidity would be. And I agree with the comment on the transplants. I have a large transplant patient population as well, which is very frustrating. You know, I have had some renal transplant patients that have agreed to go on some libtayo, knowing that they may lose their kidney. But when you get into a heart transplant or lung transplant patient, which seem to be a lot more severe in my experience, there's really no options for them, which is very unfortunate.
Karen?
Yeah, I would agree with what everybody's saying. I don't have anything.
Great. All right. Any other lasting comments? Any comments regarding cemiplimab?
I posted in the chat the New England Journal article that shows cemiplimab for advanced cutaneous squamous cell carcinoma. The response rate is about 47%, which is pretty amazing. And just for the fellows on the call, you know, this case, going back to the original case, you know, you had good surgery, you had good radiation, and you still had a recurrence, and you have these creepy sort of soft tissue mets that recurred. I think the fact that we have something like this, that's a game changer. It's not, you know, more radiation or more surgery. It's tempting just to draw a bigger circle and cut it out. But I think this is a case where the biology of disease is really stacked against you. And so the way to change the game is to try something like cemiplimab, which was fortunate to work in this case.
Yeah, I agree. Well, thank you all. It's almost 8 o'clock. If there are no other comments, we're going to finish. Thank you so much for all the presenters and the panel, Dr. Ryan Gepford, Dr. Jason Rich, Dr. Cecilia Shamalbach, Dr. Karen Choi, Dr. Don Weed, and Dr. Michael Moore and Jeff Liu, and of course, Dr. TJ Al, who organized the entire session. I could not ask for a better panel and better conversation of these really complex cases. Next week is Thanksgiving. I wish all of you and your family the best of time in these hard times. I hope you're all blessed so you can see your family and spend a day with them. We have one more session left for this year, and that's in December 4th with the salivary gland. So please join us and have a very happy Thanksgiving. Goodbye from New York City.
Karen Choi did all the organizing. She deserves the credit. And great cases. Thanks, everybody. Really appreciate it.
Great job, guys. Thank you so much.
Happy holidays, everybody.
Nice to see everybody.